Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for extract 1.
Extract 1. Questions 1 to 12.
For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
It's good to see you again.
Good to see you.
And we have already gone through your history and physical. We decided that you are a good candidate for doing the bilateral fixation, SI joint fixation. That should help you a great deal. That you don't need the fusion, and that we don't need to do a piriformis release. So I think we're ready to go ahead and proceed with that if you're ready.
Okay, well, I have done a little bit of studying upon this, and I've got some questions. I wrote some questions down, and I would like you to, if you could explain the surgery to me, exactly what I will be going through and what you'll be doing to me.
Sure. The first thing that we're going to do is the morning of the surgery, you're going to go to the preoperative area. And in the preoperative area, Vicki comes in the morning of the surgery, as well as I do too, of course. But she is going to manipulate you and make sure that you feel good and that you're in alignment, in good alignment. Then you're going to be taken to the surgery suite itself, and you'll be on the gurney in the surgery suite, and we will put you to sleep there. You also get IV antibiotics at that time, and at that time they'll set you up for the neuromuscular monitoring. They'll put little needles, and they are little, and of course near sleep also anyway, but they'll put small needles in all the muscles so that during the surgery we can monitor that to make sure we're not near a nerve root. And then after that we will roll you into a prone position. The surgery is done with you on your stomach, so you'll be on chest rolls. Then we're ready. And then we'll go ahead and prep your back and proceed with surgery. Now you're having a fixation only, and what we will end up doing is putting 2 screws on each side. And the way that I determine where to put the screw in is first with an 18-gauge needle and then under the C-arm. I did mention earlier, of course, we have you on position so that we can use C-arm, which is for x-rays, or for fluoroscopy, so that we can look through and see the bones. We'll stimulate the pin, and then we'll see if we get a response from the muscles. And if we do not get a response, we stimulate up to 20 milliamp level. If we do not get a response at about 50 milliamp level, we're usually very happy with that, even if we get a little response later on. But that makes sure that we're not close to the nerve roots, which are down here. Now, after we have the pin, we're happy with that, with the positioning on x-ray, as well as with the lack of response on the stimulation. Then we'll get a screw, a titanium cannulated screw, and put that over that guide pin, and then literally put it into the bone, screw it into the bone, and compress it. So, and then after we have the screw in, and usually I'll use 35 millimeter length screws most of the time. After we have the screw in, we'll test it again by stimulation to see if there's a response on the muscles. And again, if there isn't, then we're happy with that. And then that's the first
Do you ever have to reposition a pin or
We
move a
do.
pin out?
Sometimes if we start getting response about 10 milliamps or below that, we're certainly going to reposition it. So we're happy with the first one, and then we put in a second one, which is essentially parallel, usually a little bit higher, pretty much parallel to the first one. And that's actually the end of the procedure.
Well, now, after this, how long am I going to be in the hospital?
You'll be in the hospital if you're local. We'll keep you overnight.
Okay. Okay. Now, what about my short-term restrictions right after surgery?
In the immediate period after the surgery now, we are going to limit your activity. We do want you to be active. We do want you to walk.
Okay.
But we want you to limit the prolonged standing or limit the prolonged walking to about 30 minutes.
Can you go up in that all, or like once a day?
You
or?
can. You
Okay.
can. You really will let you do what you really need to do.
Okay.
But just kind of be careful in doing it.
Okay.
The other thing we want you to not do is do any repetitive bending over, repetitive extending,
Okay.
which is really similar to most back problems.
Now, what about my long-term restrictions?
Long term, as we talked about before, no bungee jumping.
I
things like
promise
that.
not to.
Okay. And then, but more significantly, even you don't want to do things that are going to be jarring to the back. Specifically, even stair climbing or not stair climbing, but the stair master type of
Okay.
aerobic exercises. It would not do that. I think swimming would be much better.
What about yoga? Because I've done yoga for years.
Yoga, if you avoid the extremes of it, you can do the yoga. think
I don't
yoga
do
would be
the
fine.
extremes of it. My body won't do the extremes of it. What about, I was curious about the screws. Do they ever work their way out?
No, they don't. There is a possibility they could possibly become loose, but really we've not had that problem either. The screws are made of titanium, and the titanium really attracts the bone to grow right up to it, much more so than stainless steel. So they're not going to work their way out on their own.
Now, is there a difference between a fixation and a fusion?
There is a difference. You're just going to have the fixation.
Okay.
And
That's good. That's good to know.
So these are really two different things.
That is, now, the other thing, when you fix the joint, which it's not moving anymore, do I lose any motion, or is my body going to be able to tell that?
Of course, the whole idea of this whole procedure is to limit what I call micromotion, which in this case you always are supposed to have a little micromotion in that joint. But if you have excessive motion, it leads to the problems like you have. So we are limiting that motion. We are twisting.
So I can continue on afterwards.
You can continue to actually do a lot better because it's not going to hurt you.
Exactly. That is true. That's true. Now, speaking of pain, what about post-op pain? How much pain is involved with this?
You are going to have some discomfort, especially in the immediate post-op, but it is it's a post-operative pain. It's not the same pain as what you had beforehand.
Okay.
And usually is not that severe that you cannot get up on the morning or on the afternoon after the surgery. We usually do these surgeries first thing in the morning so that, and then by the afternoon, usually we try to get you up with physical therapy. And most everyone responds that most of their preoperative pain is gone, if not all of it. But they still have some of the postoperative pain, but it's much more tolerable for them than the preoperative pain was. And of course, that's going to lessen. Even by the next morning, that's markedly lessened.
I am ready to have this surgery. You've answered my questions, and I think let's just go for it because I am very ready.
That sounds good.
Extract 2. Questions 13 to 24. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
You hear a doctor talking to a patient.
Hello, doctor. Good morning.
Good morning. What's your problem?
Well, I have a headache and pulsatile tinnitus. For the past 3 months, I've been getting severe headaches, and almost daily. I'm getting pulsations in the head with heartbeat sounds.
Exactly at which point of your head do you feel pain?
On top of my head.
Are you getting nausea or vomiting associated with the headaches?
No, doctor.
Is there any previous history of headaches?
No, doctor. But apart from last 3 months.
What's your age?
44, doctor. When I speak on the phone, I get weird sounds in my left ear. I get pulsating sounds only in left ear.
When did this problem start, actually?
Well, actually, the ear pulsations began following a flight trip to my native place.
Is there any drop or change in hearing?
No, doctor. But I had dizzy episodes in the past with nausea being imbalanced at times.
Is there any change in your vision?
No, doctor.
Well, do you smoke or drink?
I do not consume alcohol, but I used to smoke 1 pack a day, and now I have completely stopped it.
Have you had any previous illness or surgeries?
I had skin cancer on my arm and back. I am a kidney donor, so I had a left nephrectomy, C-sections, mastoidectomy, laparoscopy, and temporal arteritis.
What medications are you taking?
Tylenol, Excedrin, and a multivitamin and probiotic.
Are you allergic to any medicine?
Yes, to codeine and penicillin.
Tell me your family history of illness.
Well, my father has a cancer, hypertension, and heart disease.
Your physical examination shows your blood pressure at 120/78, pulse 64 and regular, and the temperature is 97.4. Cardiovascular test shows regular heart rate and rhythm without murmur. There is an old mastoidectomy scar on your left ear. Weber exam is midline. Grossly hearing is intact. You have pulsatile tinnitus. Left ear with eustachian tube disorder as the etiology. There's also a possibility of normal pressure hydrocephalus, deviated naval septum, dizziness, probably due to possible Meniere disease. I would recommend you to start a 2-gram less sodium diet. I am ordering a carotid ultrasound study as part of the workup and evaluation. Since your disease is related to eustachian tube, I'm prescribing Nasacort AQ nasal spray, 1 spray each nostril daily. You use the hearing protection devices at all times. I will recheck you in 3 weeks.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a patient talking to a dental receptionist. Now read the question.
Hi, I'd like an urgent appointment, please.
Let's see, who's your usual dentist?
Mr. Garcia?
You say it's urgent. Are you in pain?
Yeah, it's the tooth Mr. Garcia filled last week.
Well, he's away today, I'm afraid, but there's a free slot this afternoon with his colleague, Mrs. Brown.
Well, that'd be okay, but are you saying Mr. Garcia could fit me in tomorrow?
That's right, we'd get you in first thing. Can you wait?
Well, I'm not chewing on that side and I'm taking paracetamol, which is helping. The pain started when I was eating a steak, so I'm frightened I might have upset Mr. Garcia's work. It makes sense for him to check it out.
OK, we'll book you in for tomorrow morning at 10.
Question 26. You hear part of a presentation to nursing staff about an extension to visiting hours. Now read the question.
Now, you'll have received the survey asking your opinion about extending visiting hours, and doubtless you've got your own ideas about the possible impact on your work. You're probably aware of the evidence pointing to the positive effects on patient recovery rates of increased contact with loved ones. This isn't in question, but of course things must be managed properly. I've heard concerns about how busy everyone is, that you've got enough on your plates without having to worry about extra demands from visitors. Well, we've carefully planned things to prevent you being overrun with queries, interruptions and so on. Visitors will be given a list of do's and don'ts outlining what's expected of them. Meanwhile, managers will be monitoring things carefully to make sure routines aren't disrupted at all.
Question 27. You hear a surgeon discussing a patient with a nurse in the recovery ward. Now read the question.
It looks like Mrs. Jones is still a bit groggy after her thyroidectomy. Will she be going up to the ward soon?
Yes, I'm going to call a porter. She should be going up in 15 minutes.
OK. I've added some extra post-op pathology orders. She may have problems with the drop in her calcium. Her thyroid was just huge. We didn't see all 4 parathyroid glands, and we need to check that they haven't been affected by the procedure. She seems OK, but I want her calcium level checked twice a day. She needs to be monitored for any breathing problems, muscle cramping and numbness, and for tingling in her fingers.
OK, I'll make sure a report to watch out for hypocalcemia is passed on.
OK, if you need me, call me.
Question 28. You hear a chiropractor briefing a colleague about a patient called Ryan. Now read the question.
Today we're going to start with Ryan. He's 2 weeks post-surgery for a torn rotator cuff. He also had a spur on his acromion process removed. This is his first time in rehab post-surgery, I believe.
That's correct.
Okay, so today we're going to begin utilizing high-frequency vibration to break up the scar tissue forming in his left shoulder joint following the surgery. We're going to do each of his treatments that way, so you'll see a progression over time, how we get him back to a point where he's able to live his normal life. Movement's the key to rehabilitation, and this treatment resonates with the nerves too, so it should eventually help them heal quicker and reduce his discomfort.
Question 29. You hear a surgeon talking to a group of medical students about patient risk in emergency surgery. Now read the question.
If you look at the risks of elective surgery, they're really very low compared to emergencies. Clearly, then, we can make the biggest difference in reducing risk and improving outcomes in emergency surgery. Our mortality outcomes here are actually below average. We're at 8% compared to around 13% nationally. The emergency patients I handle tend to be older, so they're at higher risk. And when they come in, we haven't got long to prepare them in order to reduce any risks, maybe an hour or two. In terms of patient safety, every minute, every half hour we can use to get them ready counts. That's because the patients we're thinking about are prone to developing post-operative complications, given that they have a range of associated heart, kidney, and lung problems.
Question 30. You hear a surgeon talking to a patient who's just had a knee operation. Now read the question.
How are you feeling, Mr. Shaw?
Oh, exhausted. But the painkillers must be working. I can't feel my knee as you predicted.
You're bound to feel weary after an operation. It went well, though. We cleaned out loose cartilage from the joint. You can go home now.
Oh, thanks. I had an arthroscopy on the other knee several years ago, so I know what it's like. The idea that it gets done in less than a day is still pretty mind-boggling, though.
You'll need crutches for 2 weeks, but you should be walking okay within a month.
Oh, good.
Give it 4 months before you put any serious impact on it, though.
4 months? After my last op, I started running again within a month. Thinking about it, though, I guess I paid for it. That knee had a lot of niggles for months afterwards.
Yeah, if your body's hurting, it's telling you something.
Okay.
This is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear the lecture given by a physician on different categories of strokes and their location. You have 90 seconds to read questions 31 to 36.
Doctor, please explain different categories of strokes and their location.
Well, there are many different types and categories of stroke. The 2 main types of strokes are defined by their location and by the cause of tissue damage in the brain. Cause of tissue damage. Often the causes can help determine the prognosis and appropriate method of treatment. Stroke caused by a blood clot is known as ischemic stroke, caused due to the lack of blood supply, oxygen and vital nutrients to a specific region of the brain tissue. An ischemic stroke may be caused by an embolus, a blood clot travelling from another part of the body. It may be caused by a thrombus as a result of a cerebrovascular disease. Or it may be caused due to vasospasm, the sudden severe narrowing of a blood vessel in the brain. Bleeding of a blood vessel in the brain results in a hemorrhagic stroke. At times, the rupture of a brain aneurysm causes bleeding. Extreme changes in blood pressure may trigger the rupture of a brain aneurysm. At times, a region of the brain that was damaged by ischemic can bleed within the first few days after a stroke, causing a secondary hemorrhage. A watershed stroke is caused by low blood pressure or low blood flow, compromising the blood supply to susceptible regions of the brain. A watershed stroke may occur in areas of the brain that are supplied by tiny arteries. Strokes are also characterized by their location, since the affected part of the brain links to specific neurological or behavioral deficits. A cortical stroke affects the cerebral cortex that controls high-level processing. Different parts of the cerebral cortex control different functions. Frontal cortex or frontal lobe stroke often causes muscle weakness on the opposite side of the body and trouble with decision making. Patients with a stroke involving the frontal cortex may display socially inappropriate behavior, paranoia, or may regress in maturity. Occasionally, this may result in loss of bladder or bowel control. The parietal cortex is involved with integration of language and sensation. Patients with a parietal stroke often display impaired sensation or trouble with speech. The occipital cortex involves vision. Therefore, a stroke in this area may cause partial or complete loss of vision on the opposite side of the occipital region affected. The temporal cortex is involved with language and hearing. Patients with a temporal lobe stroke often have trouble understanding the spoken or written language. A subcortical stroke affects the deeper regions of the brain. Usually, a thalamatic stroke causes significant sensory deficits on the opposite side of one or more parts of the body, even when the stroke affects a relatively small region of the brain. A stroke affecting the internal capsule may affect sensory or motor function of one or more parts of the opposite side of the body. A brainstem stroke causes a wide variety of symptoms and signs. It may cause weakness, sensory changes, or troubled speech. This condition can affect the movement of the opposite side or the same side of the face or mouth. Patients with a brainstem stroke may have trouble with eye movements, manifesting a double vision or blurred vision. In addition, the brainstem controls breathing and regulates the heart rate. A brainstem stroke may affect vital functions, even when a relatively small area is affected. Some strokes are named after the blood vessel that was bleeding or blocked. The most commonly identified blood vessel in a stroke is the middle cerebral artery that causes a large cortical stroke affecting the temporal and parietal lobes.
Now look at Extract 2. Extract 2. Questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Breast cancer is not one single disease, but actually 10 distinct types of tumour, dependent upon a woman's genetic makeup. That is the finding of the largest ever study of breast cancer tissue and could provide more targeted treatment. Our science editor, Tom Clark, is here to tell us more. Tom, it sounds dramatic, 10 different diseases, effectively.
This study is one of the most sort of powerful in recent years to illustrate what new genetic technologies are allowing scientists to do in sort of redefining how they understand disease. And it's a big step towards this idea of tailoring disease treatment to the individual, this idea of personalised medicine, in this case for breast cancer. Nowadays, today, at diagnosis, how serious a breast tumour is largely judged based on how well tests, how it responds to tests for the two particular breast cancer drugs that are available to treat the disease. And this study sort of turns all that on its head. It looked at 2,000 tumours from women in the UK and in Canada. It's the largest study of its kind. And what it found, by looking at thousands of genetic mutations within those tumours, is that yes, breast cancer isn't one disease, but it falls into 10 very discrete genetic groups. And which genetic family the breast cancer belongs to has a strong bearing on how serious that tumour might be and how well it responds to treatment. For example, one class that they've identified, which according to current tests would be grouped as quite difficult to treat, in fact only has about a 10% mortality rate after 10 years, not such a severe type of cancer. Conversely, another group that they've identified, which would have a sort of fairly positive treatment profile based on current tests, would in fact has a 60% mortality after 10 years, a really nasty type of tumour. More interestingly, another new class that seems to belong to these very lucky group of women whose immune system gets involved and sort of fights their cancer for them, of particular interest to scientists. And as the report's author told us earlier, this should ensure in future that women get the right treatment for their disease.
If it's 10 diseases, it means that they will require different diagnostic procedures, they will be associated with different clinical outcomes, and they will require different treatments. And so it's a big step forward in terms of how we manage women with breast cancer and how we need to not think of it as one or two or three diseases, but a much more complex entity that will require, therefore, more tailored treatment.
More tailored, so less mastectomy, more mastectomy, less tamoxifen? I mean, how's it going to look?
Won't dictate how a doctor, the tools the doctor has in his armoury to treat cancer, but it will prevent, for example, it will help identify those women who've got a particularly nasty type of tumour and make sure they get the right kind of treatment early on, possibly the more radical types of treatment. But it could also, on the other hand, and just as importantly, spare some women very toxic, very expensive chemotherapy that their tumour might not necessarily need. I should point out that they've identified these 10 groups. It doesn't mean these tests will be available tomorrow. They've got to do clinical trials to prove that what they've seen in this study translates into the hospital environment. But Cancer Research UK, which funded the work, and now immediately they're going to start funding trials to look into this. So there's the chance that women who are newly diagnosed with breast cancer will be able to enroll in those studies. I'll just mention one more thing. Looking at all these, you asked about new tools in the armoury. Women, by looking at so many genes in this study, they've identified some quite promising new targets for those, for companies to look at to develop new medicines for treating breast cancer.
Tom Clark. Now, a quick summary of tonight's news at 7:29. A Libyan military commander is taking legal action against Jack Straw following allegations the former Foreign Secretary personally permitted his illegal rendition. Lawyers representing Abdul Hakim Belhaj confirmed legal papers had been served on the MP. Unemployment in Britain has fallen for the first time in almost a year. The jobless total fell by 35,000 in the quarter to February to 2.65 million. The government says the figures were a step in the right direction. Anders Breivik, who killed 77 people in a bomb and shooting attack in Norway, told a court that the death penalty or a full acquittal were the only logical outcomes for his massacre. And Home Secretary Theresa May has dismissed terror suspect Abu Qatada's latest bid to avoid deportation as a delaying tactic. His lawyers lodged an appeal with Europe's human rights judges, effectively blocking the government's attempts to deport him to Jordan.
And still to come tonight.
Court.
In a moment, cameras are allowed in court for the first time to record the sentencing in a murder trial. Is this the start of a revolution in how we view justice? And at 7:38, Inspire a Generation. The Olympic motto is unveiled as the 100-day countdown begins.
I wonder how head injury can lead to a condition like this.
I realize your anxiety. Definitely, I will help you to sort it out. But before moving further, would it be okay if I can ask you some questions?